In this narration, we will cover alterations of digestive function in children. So some of these are going to be congenital and some of them are going to be different, some of the differences between our kids and our adults for the same disease process. All right, so first of all, cleft lip and cleft palate. These are two developmental disorders that come specifically from um, a variety of factors. You've got a lot of different things that can contribute to this, including alcohol and tobacco use by mom, presence of diabetes in mom, certain vitamin deficiencies like vitamin D, vitamin B. And what happens is that the not enough of the mesenchyme layer goes into a certain spot to help develop the face. Okay. And so we have cleft lip, which is where it just affects the lip here. This is the same little boy at birth and then after he had it repaired. So in a cleft lip, you've got the incomplete fusion of either the nasomedial or the intermaxillary process during the second month of development. And usually it's just under one nostril, but it can be bilateral. So we can see it bilaterally. That does happen as well. Cleft palate is where it's not just the lip, but it goes all the way back the roof of the mouth. And this is during the third month of pregnancy. And you can see here that it's usually associated with cleft lip as well. Again, this is the same baby after surgical repair. So you can see here it's affecting the lip, but it's also all the way back through the mouth. Now here's more of a diagram piece of it. So here you've got just a cleft lip, and you can see there that the palate is fine. Here you've got a cleft lip and cleft palate. Here you've got a bilateral one. And then here's a cleft palate that's not associated with a cleft lip. So see, from the front, baby looks fine. And what we'll find is that the babies have feeding difficulties here, okay? So they're going to they have problems latching, they have problems sucking, and so those are usually the first things that that they'll notice if they don't have a cleft lip. Now, if they have a cleft lip, obviously we go and we say, okay, how bad is it? Is it also associated with cleft palate? Things like that. And then the way we treat it actually is they surgically correct it, and I showed you a couple pictures of that. And they do have to have, they often have speech therapy, and they have to have orthodontist follow up later to help them with their with the shape of their jaws and stuff like that. So, all right, esophageal malformations. So there's a couple of these, and first of all, esophageal atresia. So this means that the esophagus just ends in this blind pouch here. Now, there are different types of this that you may have. So here you'll notice that you've got this esophageal atresia where the esophagus, it's a pouch. It's not here and here. It's just a pouch. Now, it's commonly associated with what we call a tracheoesophageal fistula, which is where there is an opening here between the trachea and the esophagus, okay? And so now that could be something, it could be any of these things. So this one, it has an opening between the blind pouch and the trachea, which means that as they eat, food goes into their lungs. Or it could be this one, where you've got a fistula between the trachea and the stomach piece, in which case they get a lot of air in their stomach. This one, it goes in and back out, but you typically, you may not have a lot of mixing of food. You may not have much food going in. And then in this one though, you've got total mixture, right? You've got food going into the trachea, you've got air going into the stomach. So if it's one of these where it ends in a blind pouch, we are going to notice this right away because the infant is going to have projectile vomiting, okay? Because it doesn't have anywhere to go. Now, if it's one of these, we're going to notice respiratory distress, okay, with or without projectile vomiting. If it's something like this, okay. So, and this will be something that they do have to do imaging studies for. So some of the things that we see associated with it, polyhydramnios is when mom has too much amniotic fluid. So we may see that in utero, and that's going to be one of the the things then that at birth we look out for, right? They are going to have pulmonary complications. They're also often accompanied by certain cardiovascular anomalies. So if you've got some genetic malformations here, then we're going to look for genetic malformations in the heart as well, okay? Because, something wasn't working right genetically. So how do we know that we have it? Obviously, I talked about imaging. The other thing is that if we do have baby with projectile vomit and we may suspect something like this, we will try to put like a tube down, right? Like an NG tube to see if we can get it down into the stomach. When I put evaluation and treatment on here, you don't really need to know that. You need to know the diagnostics, like lab results, but you don't generally need to know how we treat things. Unless I have it specifically in one of the teach me about things. Okay. All right. Pyloric stenosis, another thing where we can have projectile vomiting. So I did talk a little bit about pyloric stenosis earlier, but so normally you've got the stomach that empties into the duodenum through the pyloric sphincter. Now, if when you have pyloric stenosis, either that sphincter is abnormally tight and won't expand, or the sphincter is super, super inflamed and swollen, and the opening in between it, even though the sphincter is trying to open, it won't open enough. Okay. When you have this, pyloric stenosis is typically not a nervous system problem where the nerves won't let it relax, okay? Typically, it's that this tissue is just super, super swollen, and no matter what the sphincter does, no matter how far open it tries to get, it can't. And so, again, we'll get projectile vomiting. This is more common in full-term male babies. We don't really know why. So, but typically when they start to eat, more than just like a teaspoon. Okay. So remember that when newborns, well, you haven't learned, well, I don't know if you learned this yet or not in nutrition, but remember when you're, newborns, the stomach is like the size of a pea at first, right? And so they don't, once they start getting a significant amount, if they're, where they're taking maybe an ounce at feedings or something like that, then you're going to start seeing where the stomach can't empty into the duodenum fast enough. And so that's when you're going to see the projectile vomiting. And so it's going to take a couple weeks before something like this shows up. But if they start vomiting, remember, they're not getting their fluids. They're not going to get their food. They're not getting their electrolytes. And so they get very, very dehydrated. And so you're going to notice not only baby has projectile vomiting, but baby's not having enough wet diapers. Okay. And they're losing weight. Instead of gaining weight. So this is a picture of a child with pyloric stenosis, and you can see here, this is his stomach. You can see how enlarged it is because it can't empty. Okay, so and you can feel the pylorus, and so they got to give them IV fluids, okay, because they're super, super dehydrated. And then what they actually do is this is how they treat it. They actually put a balloon in between right in the middle of the sphincter, and they inflate the balloon so that it dilates that sphincter, and so that the stomach can then empty. All right, intestinal malrotation. So this is a picture of intestinal malrotation here. So you can see that the intestine doesn't look right, right? I mean, it's not twisted right. It's not curled and looped the way it should. And so normally, as the fetus is developing, then this is it develops so that you've got your small intestine that comes off, and then it goes through here, and then here's where the normal link to the large intestine would be, and it would go up and over and then back down. Well, here you can see you've got small intestine like just all over the place, not normal. And there's bands of tissue that are holding it in spots that it shouldn't be. They're actually called lad bands, and that's this picture right here. Just shows you the lad bands or lads bands or whatever. Now the problem with this is because it's not rotated correctly, you can get it can actually twist in on itself, and if you've got your intestine twisted, nothing goes through the twist. Okay, and that can end up as a surgical emergency there. And so what happens, here's some more pictures here. So this twisting is called a vulvulus. And it is a surgical emergency because nothing's going to move through. And you can see here on an x-ray, you can tell that like everything just ends. I mean, here's the stomach, and here's where it's supposed to be the small intestine, but then we've got large intestine wrapped around here. And so that's what you're seeing on this x-ray here. And nothing is moving here at all. So your patient, and this is found in babies because it's not something that is not going to come out until you're an adult. Okay, this is a congenital issue that's going to come out at a pretty young age. So they're going to stop pooping. When they do poop, it's going to be liquidy and bloody, and it's just whatever can ooze past there where it's twisted up on itself. Okay, and solid stool can't. Solid stool can't go through there. They're going to be vomiting, and that vomit is often going to have digestive enzymes in it from bile backup because of the weird twisting as well. They're going to get dehydrated. They're going to get electrolyte imbalances, and so they have to have surgery. They have to have surgery to fix it, to untwist it, and hopefully get it back into position again. All right, a meconium ileus. So meconium stool is this type of stool that is in the intestine before birth. Okay, so you are supposed to have meconium. The baby is supposed to pass a meconium stool, and it's a combination of the intestinal secretions along with amniotic fluid. Okay, but every once in a while, what happens is that meconium doesn't pass. And so they get what's called a meconium ileus, where the large intestine doesn't pass the meconium. And so now you've got a backup into the small intestine. Typically, when we see a meconium ileus, when the baby is not when the newborn is not passing the meconium stool, we're going to look for cystic fibrosis. That is a ton of babies who are born with CF have a meconium ileus, and that's because the digestive enzymes are super, super thick, and so not enough of them get into the intestines, and so they can't digest. It doesn't move through the intestines in the correct way. Okay. And so what we generally do is give them enemas to get it to pass. And then we move on and to determine if what's going on that caused it. Okay. Now it's possible that they just have a meconium ileus, for a different reason and don't have CF. But a lot of patients or a lot of babies, if they're born and they don't pass that meconium stool, we're looking for CF. All right. Distal intestinal obstructive syndrome. This basically means that your intestinal contents are super, super thick, and it's like the ultimate constipation. Okay. Usually this is going to be a baby that got super, super dehydrated. So think about like some of the babies we talked about at the beginning here. Okay, so this baby who has pyloric stenosis, and he's not getting enough nutrients. He's not getting enough fluid in his system. Well, eventually, what happens then is that stool becomes really thick and hard, and it means that the intestines themselves then get bigger and bigger and bigger, and then they get impacted. So what we typically do again is an enema, but they're gonna have abdominal pain. They're going to be so they're going to be very, very, they're going to cry a lot. They're not going to want to eat. You've got other things going on, possibly that caused it, like, maybe pyloric stenosis or something. But this is just kind of the ultimate constipation. Okay. Treat it with enemas. Intestinal atresia. So anytime you have atresia, it means something didn't develop. And so with intestinal atresia, here you can see where the stomach formed, and then here's the duodenum, but now you got this big empty spot here, and you do not have a connection. And so what happens then is the food, as they're eating or breastfeeding or drinking formula or whatever, it's filling up the stomach, it's going down here, and now all of a sudden we don't have anywhere for it to go. Okay. And so when you have that, when you have this, obviously, they need to fix this. And so they're going to have to do surgery to repair it. But they will reconnect the two portions of the intestine that didn't grow together. Now, symptoms: this baby is going to be colicky. They're going to have pain. They're going to be crying a lot, very fussy. They're not going to want to eat, and they're going to be vomiting. Okay, so anytime you have and when I say vomiting, I mean, like, this is not just spitting up. Okay, this is either projectile vomiting, or this is every single bit of formula or something that the baby ate just came right back up. Okay, so it's more than just you spit up a little bit when you burp. Okay, so keep in mind that when I'm talking about vomiting. All right, Meckel diverticulum. So a Meckel's diverticulum is, so remember we talked about diverticulitis, right, in adults, where we have these little fingers that stick out. So a Meckel's diverticulum, though, is, that's a diverticula, okay, and it's sticking out, but it's in the small intestine, and you see it as a child, okay? So this isn't an adult who develops abdominal pain because they've got that little outpouching thing in their large intestine. This is different, okay? So you've got this little finger sticking out, and here's a nice picture of it. You got this little this diverticula sticking out there, and it's in the small intestine, okay? So and this is actually the most common congenital malformation, and what happens is that they start pooping blood, okay? Or you'll have blood in the diaper when there's no stool. And that's because of this is inflamed, and so it is, with that inflammation, it does start to bleed. And so you do get blood in the stool there, okay? Now, with this Meckel's diverticulum, this particular problem here, now this is what happens when we fix it there. You can see they removed it, and then they sutured together the two ends there. It is commonly associated with intussusception, and we're going to talk about that. It's in a couple of slides, I think. But you can see here that we often see the two together. And intussusception is where a piece of the small intestine literally like pockets itself into the large intestine. And so we're going to talk about that in a couple of slides. So, but Meckel's diverticulum, remember that's going to, it's painless bleeding, either with stool or on its own, and it's the small intestine instead. All right, Hershbungs disease, also known as congenital aganglionic megacolon. So what happens here is that you've got a section of the colon that doesn't have any nerves innervating it, okay? And when you don't have any nerves in a section of the colon, peristalsis doesn't occur. And because there's nothing to stimulate that that smooth muscle to move. And so what happens above it then is that this just gets dilated massively. So that's why they call it megacolon. And it just fills up with all of the intestinal contents, but then it stops because it can't go any further because it's not moving here. Okay. So the part that doesn't, this aganglionic, that means lack of nerves. Okay. That piece is the part that has to be removed. Because it's going to be, this is basically just like a wall. Nothing can go past it. So you get baby gets a very large abdomen, and then they're not passing stool. And when we do an x-ray of the belly, we can see here, I mean, look at this poor baby's large intestine. It's huge there. And so what they end up doing is they end up doing surgery, and they cut out this section of it right here. And they anastomose them together, then the healthy, the two ends of the healthy tissue. And then unfortunately, it's not always a one and done type of surgery, because what can happen is that later on, another section of the colon, the nerves may just stop working. And so they may come up with the problem again. So here you can see, again, here's your picture of it where this is the aganglionic portion right above the rectum. And so the sigmoid colon is the piece that's the megacolon. So again, we take this out and anastomose it back together. So a resection and then put it back together. We are going to put them on laxatives, enemas and stool softeners to get everything moving. Okay. All right. Anorectal malformations. And then where am I with this? I think I might stop after I'm going to stop after this slide so that it's not quite such a long narration. Now I'm going to talk about intussusception first. Okay. Because I mentioned that already. All right, so anorectal malformations. So this is going to be things like agenesis, atresia, and fistulas. So remember, agenesis means that there is completely no tissue whatsoever. Okay, it just didn't form at all. Atresia means that it didn't completely form. Okay, so remember that you had that the esophageal atresia, for example. So here we've got several different pictures. Okay, so this is where you have anal atresia. So see here, you've got the rectum here. It didn't fully develop. It didn't come out. So this right here is called an imperforate anus because because there's skin here, there's tissue right there. And so this is one of the reasons why almost immediately after birth, something goes into baby's butt, okay, whether and it's usually a thermometer. And if it won't go in, then they have to obviously examine it. And so they are looking for an imperforate anus, and that's it's on here. Here's imperforate anus right here. But that's for atresia. Now, it could just be that, or it could be an agenesis where here the anus didn't develop at all. It's not just that it like mostly developed and just didn't go through the skin. There's nothing there. So obviously surgical intervention is necessary for both of those. Okay. A fistula is an opening where it shouldn't be. Okay. So here you can see you have an opening here between the vagina and the colon. So this is a rectovaginal fistula here. And then this one is a rectoperineal fistula here. And so you can you can have all of these little things, and they're all congenital malformations, and it's just a matter of identifying what it is. Now, fistulas, everything works, but you run a really high risk of infection there because you can have rectal contents, intestinal contents going up inside like the bladder and the vagina. So, All right, so intussusception, I mentioned this once already with the Meckel's diverticulum. So intussusception is where it telescopes in, right? So you've got this piece of the intestine just like folded up on itself. Well, what happens though is that it can't go anywhere, okay? So this is not really an opening here. It's folded up on top of itself, and this is what it looks like. So you've got here's the piece of intestine, and it's going inside this one, and then it loops back around. So this is an obstruction, and baby's going to have a lot of pain, going to be extremely fussy. Abdomen is going to be distended, and when they do an X-ray, when they do some imaging, what they're going to see is that everything stops right here, because it's folded back on top of itself, and nothing can move. And usually, if we have an intestinal obstruction, this is the cause right here, is intussusception. And so the way they actually fix this is they do an air enema. And that air, when you put it up in here, it causes it to undo itself. Okay. And so it'll slowly ease back up, and now and then it all is open again. So, and then but surgically, they can also go in surgically and snip that piece out. But an air enema is the first thing that they try. I don't have that on there, but that's what it is. All right, I'm going to stop here, and I'm going to pick up with the rest of the slides in my next narration.